Hello everyone, welcome back to this video. Here we will discuss about the tubal factors, cervical factors and the uterine factors. So coming to the tubal factors. Tubal factors, it is affected by endometriosis, pelvic inflammatory disease and genital tuberculosis. What this causes? This causes distortion of the anatomy of the tube and decreased motility of the oocyte from the ovary to the uterine cavity. So, what it happens? Then that leads to infertility. So, what are the causes? Endometriosis, pelvic inflammatory disease and genital tuberculosis. What is the investigation of choice? The first line investigation of choice for tubal factor infertility is HSG. What is HSG? That is hysterosalpingogram. Hysterosalpingogram. What is the gold standard investigation for tubal factor infertility? Gold standard is laparoscopy and chromoperturbation. See, what is HSG? Hysterosalpingogram, what we do in the uterus. See, there is presence of uterus and cervix. So, in the cervical canal, we inject the dye. Okay, 15 to 20 ml of dye is injected. That is radio opaque dye is injected. And then we take a X-ray. And what happens? We see the uterine cavity and the patency of the fallopian tube as well as the spillage. Okay. So, this is the hysterosalpingograph. Any defect in the uterine cavity or the cornual spasm, this can be detected in the HSG. So, that is the investigation of choice for tubal factor infertility. And what is the gold standard investigation for tubal factor? The gold standard is laparoscopic. That is the direct visualization of the fallopian tubes through the abdomen, and chromoperturbation, that is through vaginal route we will inject the dye. Okay, methylene blue dye we will inject and we will see the patency of the tubes. Okay, and also if there will be any physiological spasm, this chromoperturbation we can correct the physiological spasm or cornual spasm can be corrected. So it is also therapeutic, diagnostic as well as therapeutic. So that is the gold standard. But as the laparoscopy is an invasive procedure, so the first line investigation is the non-invasive procedure, that is the HSG or hysterosalpingogram. So what is the indications for HSG? First, the indication is to know the patency of the tubes. To know patency of tubes. Then Asherman syndrome. In Asherman syndrome, the HSG appears. See, this is the normal HSG. Okay, this is the X-ray. Here in this portion, this is the cervix. Okay, so this is the leech Wilkinson's cannula. So in the cannula we inject the dye and then the uterus is filled and then the tubes are filled, and this is the bilateral spillage. Okay, this is the tube, this is the fimbria and this is the spillage. Okay, so this is the normal salpingogram. Then to know the patency of the tubes, to diagnose the Asherman syndrome. In Asherman syndrome, the HSG picture will be honeycomb appearance. Okay, there will be filling defects in the uterus. Then to diagnose polyp, submucous fibroid and Mullerian anomalies. So these are the indications for HSG. Then at what time we will do? Preferable time is day 10 of menstrual cycle, because in the second half of the menstrual cycle, what happens, if there will be implantation of the embryo. By chance, if there will be implantation and we do the HSG, so the embryo will be destroyed and there will be implantation failure. So to prevent the abortion or miscarriage of the fetus, we do in the first half of the cycle, that is from day 10 of the menses. The range is like from the day 7 to day 11 of mens. See, this is the normal hysterosalpingogram. So it helps to assess the uterine cavity as well as the fallopian tube. And it is a OPD procedure, does not need admission. Okay. And also does not need anesthesia. There is no hospital stay. And it is performed by injecting dye. Injecting radio-opaque dye, that is urographene. Okay, using Leech Wilkinson cannula. I've told you about the Leech Wilkinson's cannula. We will put it in the cervix and then we will inject the dye and capture the photo. Okay, and then X-ray films are taken. X-ray films are taken. Okay, under fluoroscopy. To see the patency of the tube. Okay, then there will be pain. Okay, as it passes through the internal os, so there will be pain. So we give NSAIDs to decrease the cramp, or lower abdominal pain will be decreased by the NSAIDs. What is the demerit? It cannot differentiate between cornual spasm, that is physiological cornual spasm, and actual cornual block. So that is the demerit. Then also it cannot visualize the exterior of the tube. Okay. So what are the demerits? That it cannot differentiate between the cornual spasm, that is the physiological cornual spasm. Due to the process of HSG itself, there occurs spasm of the cornu. So that will mimic as block. Okay, bilateral proximal block, it will mimic as block. So we cannot differentiate that in HSG. And also we cannot visualize the exterior of the tube. That will be best visualized in laparoscopy. Okay. Then coming to the tubal block, it occurs in 3 levels. First is proximal, then mid-segmental, and then distal block. We will now discuss about the causes and the management. Okay, so tubal block, it occurs at 3 levels. First is proximal, then mid-segmental, and distal. Okay, so the proximal block is due to cornual spasm. Most commonly it is due to cornual spasm due to the procedure of HSG itself. Cornual spasm at the time of HSG itself. Okay, so what we do tubal cannulation. We put a cannula and try to open, or we can do catheterization. Okay, tubal cannulation or catheterization, followed by chromomotivation. If here the block is not relieved, if block is not relieved, then that is pathological. Okay, and the most common cause is genital tuberculosis, that is proximal corneal block. Okay, then we have to manage by management is IVF. Okay, in vitro fertilization. Then coming to the distal. Okay, the distal part. See, 85% of all tubal infertility is due to the distal blockage. Okay, so majority is due to distal blockage. All tubal infertility. And secondary to variety of inflammatory conditions like infections, then endometriosis and other pelvic or abdominal, previous pelvic or abdominal surgeries. That leads to adhesions and distal blockage. So the distal blockage can be mild or severe. If mild, see the blockage can be mild distal block or severe. If there is severe distal block, then we have to do IVF, and if there is mild distal block, we will do fimbrioplasty. Okay, then coming to the mid-segmental block. So mid-segmental block, mostly mid-segmental means in the middle of the fallopian tube. So mostly that is because of the tubectomy. Okay, where that is bilateral tubal ligation. Okay, that is done as a family planning operation. So the most commonly it occurs due to in the tubectomy patients. So the treatment is recanalization. Okay, they regret it later, they want more child, and then they try to reverse the tubectomy procedure. So we can do tubal recanalization. So here it is most commonly seen in tubectomy patients, that is bilateral tubal ligation, and the management is recanalization or tubal recanalization. So reversal is best when there is the previous tubectomy, that is tubectomy was done by clips. Then second best is by the fallope rings, because if previously clips was given, we just remove the clips and then the blockage is gone. So that is the easiest. And second best is the fallope rings, and then is the modified pomeroys, and last is the cauterization. Cauterization has the poor prognosis of tubal recanalization. Okay, and best result is with best result if there is isthmic anastomosis. And also result is good if the age of the patient is less than 35 years. Okay, in less than 35 years, because the age is less, so there is best result. Okay, then coming to the cervical factor. See, in cervical factor, what we know is that due to abnormal or deficient cervical mucus, infertility can occur, and that is due to infection, due to cervical infection, or prior cervical surgery. Okay, prior cervical surgery, then use of antiestrogens, and presence of anti-sperm antibodies. What happens in infections? In infections, we will give antibiotics. Okay, in infection, we give antibiotics. If prior cervical surgery, we can do cervical encerclage and use of antiestrogen. Why? Because estrogen makes cervical mucus thin and helps in penetration of the sperms. So, and presence of anti-sperm antibodies, it kills the sperm and hence prevents the fertilization. So, what we do for treatment? For treatment of infections, we give antibiotics. Increase mucus thickness, we give estrogen to make it thin. Okay, or mucolytics like guaifenesin can be given, but the role is controversial. And anti-sperm, in case of anti-sperm antibody, we can give. To detect it, we do post coital test or Sims test or Hanna test. What we do here? What we do? We assess the quality of cervical mucus and presence and number of motile sperms. Presence and number of motile sperms, because motility is also a factor that helps in fertility, and also interaction between the mucus and the sperms. That also can be known by postcoital test. Interaction between mucus and sperms. Okay, then what is the count? If the count is less than 10 per high power field, that means we need to do complete semen analysis. That means something is wrong. Sperms are being dyed So we need to do complete semen analysis because there may be also male factor infertility. Okay. And then what are the prerequisites for postcoital test? To detect the anti-sperm antibodies, first, abstinence for 2 days. Refrain from sexual intercourse for 2 days and then intercourse just 2 to 8 hours before the test. And no use of lubricant. Okay, and also here normal sperms shows slow and forward motility, but in the presence of anti-sperm antibody there is corkscrew or rotatory. Okay, there is rotatory motion of the sperms. Rotatory motion of the sperms. Okay. Rotatory motion of the sperms. Now, coming to the confirmatory test for detecting the anti-sperm antibodies. What are the confirmatory tests? These you have to remember. Confirmatory tests are anti-sperm sperm agglutination test, then MAR. What is MAR? Mixed agglutination. Reaction test, Mars test, and then immunobead test. This you have to remember. Okay. Okay, so these are the confirmatory tests. And then what is the treatment? Treatment for the presence of anti-sperm antibody is the first we have to give steroids, and mostly it does not do any positive thing, but we can try. We can give corticosteroids and we have to do IUI, that is intrauterine insemination. Okay, intrauterine insemination, but there should be absence of tubal factors. Tube should be normal, because if the tube is blocked and we give the intrauterine insemination and the tube is blocked, only the sperms will be present but ova cannot come. Okay, so in the absence of tubal factors we can do intrauterine insemination for the treatment of anti-sperm antibody. Okay, then remember few tests. Okay, first for sperm penetration. For sperm penetration we do Miller Kurzrock test. To study the tail function of the sperm we do host, that is hypoosmotic swelling test. Okay, and then to know the sperm ability to bind to zona pellucida, zona pellucida is the hemizona test. Hemizona, three zona here, bind to zona pellucida, so hemizona test. And then what is to know the permeability of the cervical mucus. Permeability of cervical mucus, we do Insler score. Okay, so these are the tests you have to remember for sperm penetration, to know the tail function of the sperm and the ability of the sperm to bind to the zona pellucida, that is the hemizona test, and permeability of the cervical mucus, that is the Insler score. Then coming to the uterine factors. See, what are the uterine factors? There may be presence of leiomyomas, there may be cervical polyp, okay, or uterine adhesions like Asherman syndrome, uterine deformities or septate uterus, biconvert uterus. So, all the following things have to be surgically treated by the hysteroscopic method so as to facilitate the fertility. Okay. So, what are the uterine factors? Uterine factors. Leiomyoma, that is fibroid, then intrauterine synechia, that is the Asherman syndrome, then cervical polyp, then uterine deformities, septa, congenital anomalies. These all are treated by hysteroscopic approach. Hysteroscopic, these are treated surgically by hysteroscopic approach. Okay, so these are the uterine factors that we need to remember or keep in mind while evaluating the patients. So, I have discussed about the female infertility, that is the uterine factors, cervical factors, tubal factors, as well as the ovarian factors. Next, in the next video, I will be discussing about the male infertility as well as the management. Okay, keep learning. Thank you.